Hello everyone, my name is Alicja and today I'd like to tell you a collaborative project between Skilled Insights, a behavioural AI startup, the University of Leeds and Health Education England, an organisation that is responsible for delivering training to the National Health Service staff in the UK. In this talk I'll cover why we need an AI-enabled solutions for continuous medical education, why motivation is a key factor in that, and how we believe personalisation can offer an effective and scalable solution. Lifelong learning is a requirement in many professions. For example, engineers, lawyers, accountants, and many more. And it also applies to all health and care professionals whose continuous professional development can literally save lives. We hear a lot about how technology could revolutionize healthcare, but that technical knowledge and skills have to be acquired, and that digital disruption can affect every single health and care worker. This has been argued in an expert report called the Topol Review, which recommends that in order to make the best gains from the opportunities that technology offers, upskilling is needed. But this is not easy. The challenge facing Health Education England is that you not only need to motivate health and care professionals who are extremely busy at the best of times, but you also need to do it at scale, since the NHS counts over 1 million staff. I believe making this HE one of the biggest education and training providers in the world. Health Education England already offers an extensive range of e-learning resources via the platform e-learning for healthcare. Since the hard work of creating content has already been accomplished by HE, we believe that to better motivate the NHS workforce to complete e-learning modules, we can use personalisation and adaptation on top of the existing platform. In that sense, personalisation really is just a cherry on the top that makes the e-learning provision more effective. And while personalisation and adaptation in learning environments can apply to very different things, for now we are focusing on motivation, as we believe this is the key to encouraging health and care workers to access e-learning resources. But how do we do that? We focus on personalising motivational messages or nudges. A nudge is an intervention which aims to steer the user towards a certain behaviour without restricting their choice. Examples of nudges are a speed sign or an app notification. They encourage you towards a certain behaviour, for example, reducing speed or checking your inbox, but they don't force you to carry out that action. We believe that this is crucial in a lifelong learning setting. Another requirement is that the nudges should be a cherry on the top and easily added to the existing HE platform. In our experiments, the nudges are presented together with a description of an e-learning module using wireframes of the current system. But before we do any personalisation, we need to know several things: which nudges to use to be effective, and how user characteristics might interact with the effectiveness of nudges. And to explore these questions, we conducted a study with medical and healthcare students where we considered several different nudges and 3 user characteristics: interest, demographics, and personality. You will find the details of the data collection in our paper. To briefly summarize, we recruited 107 students in medicine or healthcare to complete an online survey. Most of the participants were quite young and studying medicine, and most of them are also frequent users of technology for learning. I will now briefly summarize the study design. Within the survey, we asked whether a participant would choose a particular e-learning resource. We picked 6 resources on the same broad topic, child and adolescent mental health, and we added nudges to 5 of them. I will show you the resources and the nudges shortly. For each resource, we collected the score of likeliness to click and asked for an explanation for the participant's choice. We also investigated whether these learner characteristics mediated the likeliness to click. Demographics questions and mind-time questionnaire were included at the beginning of the survey, and we asked about user interest with each presented resource. These are the wireframes for the 6 resources we used in the study. Each resource is presented using a title, placement in topical taxonomy and rating, which was kept constant for all resources, a short text description, an image, and for 5 resources, a textual nudge. We used the taxonomy of choice architecture techniques to select 5 nudges which were applicable and implementable in this scenario. The paper summarizes each nudge. To explain them quickly, the feedback nudge gives the learner an idea about the progress. The external information nudge provides a statistic relevant to the topic. The opinion nudge shows logos of organizations which have endorsed this particular resource. The benefit nudge highlights points that can be awarded and being able to expand the learner's professional portfolio. And finally, the self-commitment nudge allows the learner to save the module for later. I will now summarize our findings. Our study showed that not all nudges are equal. Even without any personalization, we found that the opinion leader nudge was most effective. This is useful to know when we have a new user in the system and no user model available, or when the user does not consent to personalized content. In this case, we can just use the most effective nudge as a default. We also found that among the 3 user characteristics, interest was by far most closely linked with likeliness to pick a resource. This suggests that using a content-based recommender system could encourage NHS staff to access modules relevant to their interests. However, demographics and personality still played a role, although to a lesser degree. We believe that these characteristics would be especially useful for personalization when user interest is not applicable. For example, most health and care workers should know the basics about preventing and recognizing sepsis. In that scenario, interest doesn't really play a role. Instead, personalization could be driven by personality or demographics. Finally, a qualitative analysis of the feedback on each resource revealed that the how really matters. Participants pointed out that they are more likely to disengage if the presentation is incongruent. For example, a silly picture which doesn't match the topic of the resource. What seemed to drive engagement was informative descriptions and eliciting emotion. For example, by using a picture of a child with whom you'd empathize. Finally, as with many online environments in the era of information overload, keeping the presentation simple was highlighted as positive as well. These are the lessons that we have learned in the current study. In the near future, we will conduct a similar study with NHS staff at a large hospital in the UK. We are very interested to see which of these patterns will repeat and which might possibly differ. And I would like to finish this talk with a motivational message personalized to the Happy Workshop crowd. During this pandemic, the e-learning for healthcare website has seen a huge amount of traffic. And thanks to a huge effort by Health Education England, they were able to very quickly release an e-learning module on COVID, which has been accessed over 1.5 million times to date. And even outside of healthcare, a lot of learning has been forced to move online. And with this massive shift to e-learning, Perhaps now is the time to contribute, whether it's in healthcare, education, and others, and showcase the promise of personalization for learner motivation. Thank you very much, and I'm happy to take questions.